The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Welcome, TMD warriors. I am Tony Urbanek, and we are gathered for the next episode of TMD Demystified. Today, we're going to be talking about a very timely and important topic that applies to both practitioners, dentists, oral surgeons in particular, and even to patients. I understand that there's an increasing number of patients who view these episodes. But the topic today, having to do with TMD, revolves around the fact that TMD generates some strange pains around the face, neck, oral cavity, upper back and shoulder, etc., that we've talked about many times. But one of the very interesting things that patients frequently report, and very specifically report, is they confuse the TMD pain generated with toothache, or in my specific field as an oral and maxillofacial surgeon, impacted wisdom teeth. Now, let's tackle the wisdom teeth thing first, because in my now 50-year career as an oral and maxillofacial surgeon, I have seen many, I don't know how many, less than 500, but more than 100 episodes, many more than 100, probably something less than 500 cases of patients who presented to me on referral or their direct referral from the patient themselves, saying that their wisdom teeth hurt. And that, fortunately for me as an oral and maxillofacial surgeon, they needed their wisdom teeth out. So I would get an x-ray and do an examination and take a look at the usually 4 impacted wisdom teeth, whether the patient be 16 years old or 60 years old, and make a diagnosis and whether or not I suspected the pain was coming from the wisdom teeth. Most of the time it was. You'd have an inflammation, you'd have damage to the adjacent tooth, you could have a cyst or a tumor around the impacted wisdom tooth, but very frequently, especially in younger individuals, 15, 16, 17, 18, you take a look at the x-ray, you do an examination inside the mouth, you would palpate around the wisdom tooth, the impacted wisdom tooth itself did not generate any pain. You couldn't get pain on, quote, palpation of the area. No matter how much you pushed on the area over the impacted wisdom tooth, you couldn't generate pain. And you looked at the x-ray and you saw no x-ray evidence that that tooth should be symptomatic at all. In those cases, I would sit down with the patient or the patient's parents and the patient and explain to them the reasons why impacted wisdom teeth need to be removed, which are many. I think I still recall I don't do wisdom teeth removal anymore, but I still recall the pattern. Wisdom teeth can cause the major malfunctions are cysts and tumors, and malocclusion of various kinds. And the most important one is damage to the adjacent tooth. That actually, impacted wisdom teeth frequently cause damage, especially decay, to the adjacent wisdom tooth, needing eventually the removal of the second molars because the third molars hadn't been removed. But this is not a lecture on why you take out wisdom teeth. But I would go over that with the patient and say, you certainly need your wisdom teeth out for these reasons, but your wisdom teeth are not causing your pain. Your wisdom teeth are not causing your pain. I'm also aware of many of my colleagues, both general dentists and oral and maxillofacial surgeons, who would not go through that process with the patient, and they say, sure, well, whatever reason you think your wisdom teeth need to come out, we'll take it out. But in those cases, the patient would come back, even though their wisdom teeth were removed, and still having pain and wondering why now their wisdom teeth are out and they're still having pain. Well, most likely, I can't go back to all those cases that I observed or saw over a 50-year period of time, but it is highly likely that in each and every one of those cases, the pain that the patient thought was associated with their impacted third molar, wisdom tooth, was actually pain generated from the temporomandibular joint. And the same thing applies to the frequent patients we see who come in and claim that they have their pain is coming from a bad tooth, a toothache. And patient and general dentists are confronted all the time, very frequently, with patients who present to their office in pain, and they say, I have a toothache. And so the general dentist will then go through his usual standard consultation, x-ray examination, and announce to the patient that I don't see anything wrong with this tooth or any teeth in this particular area of your mouth, always in the posterior, always in the posterior. So there are two separate scenarios. As the patient comes in and says, I have a toothache, and the patient who comes in and says, I have pain, my wisdom tooth is hurting. Both of them, on examination, are seen to be not creating pain. There's no reason for the pain. You don't see any decay. There is no pain on palpation. There is no cyst. There is no tumor. There is no clinical reason to treat either the tooth in general or the impacted tooth. And then it is up to the doctor to inform the patient of that fact. It's confusing. It's confusing to the patient, it's confusing to the doctor. And as I've already intimated, some of my oral surgery colleagues just go ahead and take out the wisdom tooth without actually telling them that, no, I don't think your wisdom tooth is causing this pain. I don't know what's causing it. They may not, and in most cases, they don't relate it to the temporomandibular joint. But today we're going to talk about technically how inflammation within the temporomandibular joint can create in the patient's mind, in the patient's physiology, pain. Either they think it's coming from the tooth or they think it's coming from an impacted wisdom tooth. And it's easy to explain when you understand the pathophysiology of exactly how inflammation in the joint reacts, inflammation in the temporomandibular joint reacts. But so the topic of today and the title of today is, why does my TMD sometimes feel like a toothache? That's the title of today's episode. Why does TMD, temporomandibular joint disorder, sometimes feel like a toothache? Well, the explanation is the same explanation of why TMD sometimes comes across as upper back pain or upper back and shoulder pain and tightness. Also, the same explanation of why TMD, not infrequently, comes across to the patient as arm, hand, finger tingling and numbness. We've talked about that many times, but the pathophysiology is all the same. How does inflammation in that joint, from a damaged joint, you have to have a damaged joint to start with, damage due to whatever reason, there's only three causes, only three reasons that people damage their temporomandibular joint: chronic clenching and grinding, bruxism, acute trauma of various kinds, especially motor vehicle accidents and whiplash injuries, and then functional malocclusions where your teeth do not fit together evenly, significantly overloading the joint, damaging the joint. But all three of them share the concept of damage to the temporomandibular joint. Damage to the temporomandibular joint creates inflammation within the joint. If the inflammation doesn't go away, then there are a cascade of events that create these disparate feelings, these disparate symptoms around the head and the face, the neck and the shoulders, and even into the arms. So what is that pathophysiology? We've talked about it many times, but today I want to limit it to this concept of it feels like a toothache, and this is not unheard of. It comes across in many dental offices this way, and the dentist scratches his head and says, this tooth looks fine. Well, here's what's happening. Again, we've discussed it before, the pathophysiology, which is what has not been worked out before. This is why the dental schools don't teach about it. They think it's complicated. They haven't figured out what the orthopedic surgeons know about inflammation in the joint. Orthopedic surgeons know all about what they call joint splinting. When a joint becomes inflamed, a signal, a autonomic nervous system, a nervous system signal through the autonomic system, sympathetic portion, sends a signal to the brain, specifically in and around the brain stem, says, I'm inflamed. So there's a signal, a message that's sent from the joint through the nervous system to the brain that announces, I'm inflamed. I need help. And the body is excellent, is an excellent mechanism. It's a self-correcting mechanism if you allow it to self-correct. And the injury isn't too bad. Well, in this case, you got a bad joint, it's inflamed, it sends a signal to the brainstem announcing I'm inflamed. The brainstem says, I see you're inflamed, I'm going to help you out. I'm going to help that joint heal. Well, what's the best way to allow a joint to heal? Will limit the movement in the joint to allow healing. If you have a bad joint, the orthopedic surgeons learned thousands of years ago, you rest the joint. If you have a bad knee, you put the patient on crutches. If you have a bad elbow, you put the patient in a sling. Now, orthopedic surgeons, have the opportunity to have external devices that rest the joint. Well, dentists and oral and maxillofacial surgeons do not have an external device that they can allow to rest the joint, but we now have an internal device that rests against the upper front teeth, disoccluding or taking the load off the back teeth, where 90% of the loads on the joint come from. So you disocclude or separate the posterior teeth, taking 90% of the loads off the jaw joint. But the point is, the pathophysiology is the same between the orthopedic joints, hip, knee, elbow, and the temporomandibular joint. When this joint becomes inflamed, it sends a signal to the brainstem. It says, I'm inflamed. The brainstem says, I'm going to help you out. Don't move the jaw, and sends out an autonomic nervous system message signal to the muscles that move the jaw, and not always to the same muscles, not always on the same side, but you will get variations of where those signals are sent. And there are many muscles, without going into the specific names. We can. And patients will complain of where those muscles are attached to the bone, whether they be attachments to the mylohyoid or the masseter or the temporalis, and patients will come in. They'll literally show you it hurts there every morning. But the point is that signal goes to the muscles that says tighten up, contract, tighten up, don't move the joint. And that is the mechanism that the dentists have never learned, the orthopedic surgeons know all about, and the reason why a device that separates the back teeth, like this device, separates the back teeth, will decrease the inflammation enough where the signals don't get sent and the inflammation goes away, because the muscles do not get the signal to tighten up. that pull on the bone, and where the muscles are attached to the bone is where it stimulates the nociceptors on in the periosteum of the bone, and patients will complain of pain here, and specifically, if the signal comes to tighten up the masseter muscle, which inserts right here, the patient can confuse that pain, which is actually pain in the bone, which is right around the tooth itself. So whether it be a second molar or a first molar or a third molar, wisdom tooth, patients will experience pain right there, right literally on the bone that supports that tooth. And patients will present to the dental office, to the oral surgeon's office, and say, my wisdom tooth hurts, or I have a toothache. I must have decay in that tooth. The workup is accomplished, the workup is done, the x-rays are taken. Nobody sees any reason to have pain. Whether or not the provider actually tells the patient the facts and the truth, sometimes it happens, sometimes it doesn't. And sometimes, unfortunately, the patients actually demand, we've seen multiple cases of that, 10s, 20, 30, 40, 50 cases of patients coming in with missing teeth because they demanded that the doctor, the dentist, take out a tooth that they believe is causing all the pain. The tooth is removed, which it shouldn't have been removed. The doctor should never take out a tooth that he knows is not damaged, but the patient demands it. Doctors give in, okay, I'll take your tooth out. They take out a perfectly healthy tooth, and the pain continues because the pain wasn't coming from the tooth. The pain was coming from the bone, which supported that tooth, and the pain after the tooth was removed continues on. Why? Because the pain is actually generated by inflammation within the temporomandibular joint. That is a fact. And we have seen many, many, many cases that are exactly like that. So, message to my dental colleagues, my dental colleagues, my oral and maxillofacial surgery colleagues. When you see a patient present to your office and says, I have a toothache, I need my tooth out, or I need something done to my tooth because I have a decay or periodontal problem, or I have an impacted wisdom tooth, it hurts, and you do your workup and you find no reason why it should be hurting, there should be no reason for that to be painful in that area, please look at the temporomandibular joint as a potential cause or source of the pain. And I just explained to you how that happens. The orthopedic surgeons call it joint splinting. You splint the joint. You splint the elbow. You splint the knee. You can splint the temporomandibular joint by unloading it. When you unload the joint, the inflammation goes down. When your inflammation goes down, the symptoms go away. But please, if you are a provider, include TMD, inflammation within the joint, in your differential diagnosis. When patients come in requesting something be done to their tooth, their impacted tooth, their infected tooth, their decayed tooth, and you find no decay, no reason for the impacted tooth to hurt. Put it on your differential diagnosis. It may be TMD, and it's easy to diagnose, tremendously easy. For the patients, they can do it at home. Open the mouth widely, put your fingers tightly, firmly into the depression where the ball now comes out of the socket when the mouth is open. Put your fingers in tightly and close rapidly. If you close rapidly and it hurts, the joint's inflamed. The definition of jaw joint problem, better known as TMJ, jaw joint problem, TMD, should be inflammation within the joint. And the degree of inflammation can vary. The degree of damage within the joint can vary, but inflammation should be the proper definition of TMD. Inflammation within the joint is temporomandibular joint disorder. It's not disorders. There's no plural to it. There's only one disorder, which is inflammation in the joint, which then can cause all the symptoms. They can also cause degenerative change and bony changes within the joint. That's what inflammation does. Chronic inflammation over a period of time can destroy the structures around it, the cartilage and the bone, and the surfaces of the cartilage and the bone. So it's really pretty simple when you understand the pathophysiology, as we say, big word, pathophysiology, of what's actually causing the disease, the cause of the disease. So why would you treat this disease? It's so easy to diagnose and so easy to treat by simply separating the posterior teeth long enough, according to a protocol, with a device they can speak with in their mouth, because you have to wear it not just when you want to. There's a protocol 24/7 for 2 months, usually nighttime only the rest of your life. But that is the protocol that works best. And when you apply that protocol over a period of time, you will get the inflammation to decrease. And as I've said now 4 times, when the inflammation goes away, the symptoms go away, because there are no additional autonomic nervous system giving signals to tighten up, pull on the bone, create the pain. Couldn't say it any better, couldn't say it any differently. And that is the reason why sometimes TMD feels like a toothache, and the doctors need to do the right thing, and the patients need the proper information and certainty, and have enough confidence in their provider to say, he must know what he's talking about. It sure feels like a toothache. I know it's a toothache. I know it's my wisdom tooth. No, he explained to me how this can occur. He explained to me how you can actually have inflammation in the joint that can create pain that feels like a toothache, feels like an impacted wisdom tooth, but is not. But there's certainly reasons to take out impacted wisdom teeth. I do not claim or recommend leaving impacted wisdom tooth behind. Why? Because they cause cysts and tumors. They can cause malocclusions, and most importantly, most frequent symptom or most frequent problem is damage to the anterior tooth or the adjacent tooth. That happens all the time, and then you end up losing teeth that you really don't need to lose. I appreciate you listening to this episode. I always do. I am certainly willing and able to communicate with anyone who'd like to communicate with me about this. I'm available at tony@tmjservices.net. Are there any providers out there, any doctors, oral surgeons, dentists, who would like to use the Urbanic device and protocol, which is patented device and protocol, which we have found is extremely successful in treating the symptoms of TMD. You can find out more about it by going to our website at www.urbanek.tmj.com. So until next time, I will look forward to our next episode. I look forward to you returning, hopefully, and choosing another topic to talk about on this podcast, TMD Demystified.